they've been suffering for the last 2 or 3 weeks. It got to the point where the patient's wife said, you must go and get this sorted because it's causing arguments within the house, because the patient kept having to ask his wife to repeat herself, and the TV was very, very loud. And so the patient was using drops for a while. They felt themselves, it was just their left ear. So this is the patient's left ear. They didn't notice that their right ear was also blocked, that they felt that they were hearing okay. And I mentioned last week that I had a bit of a problem with my ear, and it's thankfully on the mend now. But I was experiencing symptoms in my left ear, but when I tested my right ear, that was also effective, but I didn't notice, and that's purely because my left ear was so bad. My focus, my brain was being attentive to the left ear, and for that reason I felt the right ear was okay. And it's probably a similar case with this patient. Well, it was, because when I removed the wax on the left ear, they suddenly noticed the right ear was blocked. So it's always when you've got obviously 2 ears, which we have, we're always comparing one to the other, and we make our reference judgments based on how we feel one is compared to the other. So you could have 2 bad ears but one worse, and you think the good ear is normal, but it's not. It's just a better as opposed to a good ear. Now, one of the questions from the last video, someone asked, why didn't I try and move the wax from off the canal wall and go inwards? In the case of the last one in particular, was the patient had a really severe ear infection. So if you remember, they had a lot of pain in their ear. So we always want to avoid making contact with the canal wall. And even with this patient, all this patient's ear wasn't infected, and they didn't really have symptoms of otalgia, earache. The bony part of the ear canal, so the inner 2/3 in particular, it's very, very sensitive. And if you've had your ears cleaned before and someone's touched the side of your ear canals, you'll appreciate that. The outer third's okay, that's cartilaginous, it's not as sensitive, but I've had obviously people in my ears before, and if they clip the canal wall, it can be quite uncomfortable. So that's why, wherever possible, I always see if I can remove the wax from the core, from the centre first, and if not, I kind of try to go closer to the ear canal, trying to peel it. Now sometimes we've got no choice, we have to remove the canal wall. So you can see we removed the majority of the wax there. You've got this last plug, it's really stuck to the drum. So again, I'm going to the roof of the ear canal. There's a bit of a gap from the canal wall itself. I'm not going to peel it directly off that, but I'm going as close as possible as I can. I think now we can see the top part of the eardrum there. You can see there's some wax trapped in the inferior recess. So this patient really, really did impact it. I think one of the other questions were that, is it possible for fluid to enter the nose from the ear? It is possible in 2 ways. So in the middle ear, so that's just a normal healthy looking eardrum. So I'm just going to mop up around the edge of debris there. Now, so the eardrum it's got 3 membranes. The outer membrane that we can see, that's the same skin that lines the ear canal. That's an epithelial layer of skin. The middle layer of the eardrum is the fibrous connective tissue. That's what gives the eardrum its rigidity, its strength and elasticity. And the inner layer that we can't see, that's the mucosa. Now, mucosa is the same skin in our nose, and that is meant to be moist, and it secretes. So in the nose we get obviously mucus. The same with our middle ear. So our middle ear has got the ability to secrete fluids. So this fluid, generally, if it does secrete in the middle ear cavity, it drains down the eustachian tube. So the eustachian tube is the pressure equalizer in the ear. It connects the middle ear to the back of the nose. This tube, so fluid that's secreted by the middle ear cells can travel down the eustachian tube. And the eustachian tube connects to the back of the nose and nasopharynx. So yes, it can do. I'll come back to that in a moment. So with this patient, I just used a bit of suction, but it was really impacted. So I used an ear hook, but the ear hook initially just dissected the core of the wax. It went through it like a hot knife through butter, but I'm just trying to break it into little pieces. Sometimes with a hook, even if we don't manage to remove the wax, we want to just break it up into little pieces. And when it's in little pieces, we can then go back with a suction probe and vacuum it. So it's almost like a hammer and chisel effect. We're using the hook to break them into little pieces, and we can then suction up the little pieces. So I also just tried some forceps. I thought if I can get a strand of this and then remove it, it might come out in a plug. But the wax itself, it was a bit too soft. It wasn't as firm. So as I said, the forceps just kind of dissect into it. So just going back to suction here. The other way it's possible for fluid to get into the back of the nose from the ear, it still travels through the eustachian tube in the middle ear, but if you've got a perforated eardrum, a hole in your eardrum, and you get water in there or some sort of drops, the water can get through the eardrum and travel down the eustachian tube. I think another question was when I tilted the patient, when I asked the patient to lay down, or when they requested actually, because they were really in severe pain, they wanted to lay down on the couch yesterday on that procedure. I think one of the comments were that the view of the anterior recess wasn't improved by the fact that we got the patient to lay down. So that wasn't the reason actually. So I didn't want the patient to lay down, or she didn't want to lay down, so I can get access to the anterior recess. It was just purely because the patient was in quite a lot of pain. Another question was that if when we remove plugs of the dead skin and the debris yesterday off the eardrum, can the patient notice a big relief? Yes, quite often they actually comment, oh, that feels much better. So I think that was most of the questions answered. Just going back to this, this is the last bit of the wax. It's really dry now, this bit, and it is lodged in the inferior and anterior recess. Now, when you've got a bit of dry wax like this, it's matted as well, we've got to be careful, because what can happen is when you make contact with the wax, with the suction probe, it can push the wax further in and it can impact against the eardrum, so it can be quite uncomfortable. So we're trying to hover over it almost. We want to get a suction grip without making direct contact. So I'm just literally kissing the surface and I'm making these little wriggles. I'm trying to remove it from the isthmus. So near the eardrum, the ear canal narrows and it widens, and it sometimes wax can get lodged and pushed beyond the isthmus. So it's quite difficult to remove. So I just put a bit of olive oil in there just to lubricate it, to help with the suction grip. And you'll see I'm going to just wriggle this out. I'm going to manoeuvre it out. I think another question was, I think in the previous videos as well, they wanted me to hire a script writer to help me explain things differently in my videos, and also hire a nurse and who can prescribe medication. I wish I had the luxury, guys. You may think I'm a very wealthy person, but I'm not. So it's a small independent clinic. I can't afford to hire someone just to give me advice on scripts on YouTube videos or kind of to inject some local anesthetic once in a while. So I wish I had that luxury, but unfortunately I don't. So I hope that answers that question. So I've managed to remove that from the isthmus, and I'm just bringing it forwards. I'm near the entrance here. And it's just, the entrance is quite narrow. And as such, I'm just trying to wriggle this out. I think I'm going to rotate it like a ball. We'll see. I think I'm going to come down from the roof and bring it forwards and downwards. But we do manage to remove it. Now, in this ear, the patient's got a retraction. The eardrum is sucked in. It's buckled inwards due to a blocked eustachian tube. I was referring to the eustachian tube earlier, so that's the pressure equalizer. We want the air pressure in the middle ear, so the cavity behind the eardrum, to be the same as the air pressure in the atmosphere. When the air pressure either side of the eardrum is equal, that's when our eardrum is most mobile, most compliant, and that's when we hear the best. And it's a function of the eustachian tube, which connects the middle ear to the back of the nose and nasopharynx, to regulate the air pressure. Eustachian tube is typically at a resting state closed. During brief moments of yawning, swallowing or chewing, it momentarily opens and it allows air to enter or escape in order to equalise the air pressure behind the eardrum. So this patient's eustachian tube is partially blocked, which is what happened in my ear. You can see at the top, the eardrum is sucked in. There's a bit of a retraction at the top. So the eardrum's a piece of cling film. It's wrapped around the bone because it's sucked inwards. So we've advised the patient to